Now, continuing on to the fourth section, we will be discussing again the other latent complications. We have just discussed the malunion, delayed union, non-union. We will be discussing the other latent complications such as avascular necrosis, growth disturbances, and bed sores. And lastly, the heterotopic ossifications, sternal lesions, and nerve compressions, which may be associated as well with the fractures. Now, coming to the avian. Avascular necrosis, usually the region we can develop is the head of the femur, which is the most common. Other is the proximal part of the scaphoid, because the blood supply is such that usually it leads to scaphoid non-union. Other is the lunate, usually falling at perineal dislocation, and it could be the body of talus, which may be due to the fracture of the talus associated with the ankle dislocation or usually ankle injury trauma. Coming to the treatment, if it is avian of the femur, usually necrosis of the femoral head, if it has occurred and advanced beyond a certain point, usually if its patient is adult and around 40 to 45 years of age or 50 years of age, then probably the first and foremost is to go for total hip replacements. And the problem arises when we are dealing with the avian of the femur in a very young child, usually if let's suppose it's 20-25 years of age, and that's kind of a thing in which we have to consider many things. For example, multiple options. It could be in form of free vascular fibrillar graft. It could be simply reaming of the femoral head so that the blood supply can be restored as well, depending upon what is the fee card classification. But if the patient is such that it has a high load and high demand, for example, let's say a laborer, then probably instead of going a total hip, the orthodesis is the best option. We can go for it. If it's younger people, then I told you that it could be in form of realignment osteotomy, and it could be an orthodesis. Other option in case of it is necrosis, scaphoid or talus, then we have to go for symptomatic treatment. Then depending upon what is the scaphoid non-union advanced collapse is there or not, and then we can go for the treatment of the certain types depending upon what is the stage of the disease. It could be in form of 4-quadrant fixation, it could be proximal carpectomy, it could be simple fixation of the non-union. Orthodesis of wrist and ankle is an option as well, or if it's an advanced stage and the talus A necrosis is there and there's advanced collapse of the scaphoid non-union, then probably orthodesis is one of the best option we can go for. Coming to the growth disturbances and bed sores, growth disturbances could be due to the damage to the physis, which could be at the time of injury. It could be due to Salter-Harris type injury or transverse fracture, not always disastrous because they affect the growth throughout. But sometimes what happens is this crush injury that is called as Salter-Harris type 5 injury. This is not initially visible, but once the angulation develops, they can be disastrous because the one part of the physis has been crushed, the other physis is actually growing, leading to the angulation. This actually usually runs through the hypertrophic zone of the which is mainly of the growth plate, and growth may be asymmetrical and leading to angulation. Coming to the bed sores usually if the patient had associated neurovascular trauma and head injury as well, patient may be in ICU for a longer period of time and may be unconscious, or patient may have certain type of injuries such as bed sores, pelvic injuries in which the patient was immobilized for 2 to 3 weeks. Then this could result in skin over sacrum, and heels are more prone because these are areas which are dependent, and usually careful nursing and early activity prevents these bed sores. Important is depending on the grade of bed sores. If it's superficial, then we can only do the postural changes, but if it is advanced to a certain level that the subcutaneous tissues involved or become necrotic, then probably excision of the necrotic tissue and skin graft is necessary. Or if it is too deep, then we have to go the multiple debridements, and later on a flap may be required as well. The most common form is actually go for aggressive debridement, wound wash, cleaning, and then go for vacuum assisted closure. That apply a vac over the area, and once the bed has actually healed, you apply a skin graft over top of it. Now, a rare but very important also complication of one of the late complications of the fracture is heterotopic ossification. Occurs usually after injury. Most commonly, it is actually associated with craniocerebral injury, that is either the head injury or spinal cord injury, which is associated with ossification of it. This is due to the muscle damage, and usually the ossification occurs in the muscle and between the muscle and the joint capsule. Periarticular. If you see it over here, this is the muscle vision, and this is where actually the ossification is occurring. It's outside the joint and between the muscle and the joint capsule usually, and usually occurs without local injury. For example, patient may be having a spinal cord injury, a head injury, but you see ossification around the hip, shoulder, elbows, or even the knees. Although knees usually rare, but yes, they can also get affected as well. Now coming to the treatment of heterotopic ossification. The initial treatment is actually joint rested in a position of function. Condition is stabilized, and only if once these ossifications are mature, then they can only be excised. Initial treatment is usually conservative in form of indomethacin, and which is 75 milligram per day. Radiotherapy is only given if the patient is prone to developing. If patient has developed once, that means the patient is prone to developing this kind of heterotopic ossification, especially after hip or knee surgery. So if we are going for a total hip or total knee replacement in a patient who is prone to developing heterotopic ossification, then radiotherapy is a very good option that we can go for 700 centigarai of radiation, one single dose over the patient before the surgery, so then we can perform the surgery, and then probably the patient will less likely to develop heterotopic ossification post surgery in these cases. Now coming to the tendon lesions or nerve compressions. Tendon lesions could also be associated with trauma as well, usually affect tibialis posterior tendon, especially after the bimalleolar fracture. It's direct suturing is seldom possible, because if the tendon is actually avulsed from the bone, then we have to actually fix it differently, because it cannot simply be sutured back to the bone sometime. But if the tendon is actually ruptured in such a way and there is no retraction, then probably bony ends can be refreshened, and this tendon ends can be refreshened and sutured back. But although it's not always possible, usually risk is reduced by accurate retraction. That is, when we are fixing the bimalleolar fracture, we need to make it sure that we have accurately reduced the fracture, as well as our K-wires are actually, our screws are not impinging onto the tendon. That is important. Late rupture may be due to the, for example, in case of the shoulder, there may be a late rupture of shoulder head of bicep, which usually requires physiotherapy, and no operative treatment may be required as well. Coming to the nerve compression, may be due to, for example, damage to lateral popliteal nerve. Local nerve entrapment may be seen as well, which may be very painful. Sites usually are ulnar, medial, or posterior tibial nerve, which is around the elbow dislocation and around the knee dislocation. And nerve decompression is the most important way is to actually reduce back the dislocation, and usually it relieves the nerve of decompression. In this section, we have briefly gone through what are the other late complications of trauma, especially it could post-traumatically, if that was around the pelvic fractures or it was around the acetabular fractures. This eventually lately presents with AVN of the femoral head, which may eventually require total hip replacements. And late fractures of the scaphoid can present with scaphoid non-union advanced collapse, which may eventually require orthodesis of the wrist or certain treatment, if depending upon what is the stage of the disease. Leonid may be damaged as well in perileonid dislocations, or for example, talus may undergo non-union or avascular necrosis following an ankle trauma, and may eventually require orthodesis of the ankle joint as well. Depending upon, we have briefly discussed the heterotopic ossification as well, and certain people are more prone to this, and if usually the operative treatment is reserved only once the ossification has matured. But if the patient is more prone to developing ossifications or has developed once, then if we are going for total hip or total knee replacement in these patients, then probably the perioperative or preoperative radiotherapy of 700 centigarai is the most important indication, and you give them the radiotherapy before going for surgery. Thank you very much. Keep watching sqadia.com.